Good afternoon. My name is Brandy L. Lane, and I will be presenting to you my verbal dictation report. The patient is a 4-year-old African American girl who presents to the clinic accompanied by her mother. The patient's mother appears to be a reliable historian. The patient resides in Mansfield, Louisiana, and attends daycare. The patient's mother has Medicaid. Chief complaint. The mother reports that her child has had a cough and fever for the past 2 days. HPI. The patient was brought to the clinic by her mother. The mother reports that the patient has had a persistent fever and a constant wet cough that presented abruptly 2 days ago. The mother also reports that the patient has a runny nose with clear discharge. The cough is worse when lying down. The mother reports that the patient sounds congested, but the patient is not coughing anything up. The mother reports that the patient has been eating and drinking fine and has good urine output, but has not been able to eat solid food since becoming ill 2 days ago. The mother reports that the patient has been complaining of a sore throat and is irritable, and when she attempted to look into her daughter's mouth, it did appear to be red. The patient is crying more frequently, but the mother reports that the patient has good tear production. According to the mother, the coughing, fever, and sore throat is disrupting the patient's sleep. When speaking directly to the patient reported that her throat hurt. The mother denies any hoarseness. The highest temperature recorded was 101.8 axillary, which was unrelieved with alternating Tylenol and Motrin. The last dose of Motrin given was this morning at around 2:30. The patient has taken Zyrtec in the past for seasonal allergies, but the mother reports that the last dose of Zyrtec that she gave to the patient was on yesterday morning at 8 o'clock a.m. since the patient has started back having a runny nose. No improvement in symptoms over the past 2 days. The mother denies loss of appetite, nausea, vomiting, diarrhea, or fatigue. No sick contacts in the home or no sick contacts reported at the patient's daycare, but sick contacts reported at the patient's grandmother's house. The grandmother keeps the patient overnight nightly while the patient's mother is working, and the grandmother informed the patient's mother that a 5-year-old male cousin who lives in the home with the grandmother is having the same symptoms as the patient but has not been to the doctor. The patient is up to date on all of her immunizations but has not had her annual flu vaccine. Past medical history, past surgical history. The patient has seasonal allergies diagnosed about 3 months ago. No other illnesses or past surgical history reported. Allergies and medications. The patient has no known allergies and she takes Zyrtec 1 milligram per meal oral syrup, 1 teaspoon BID PRN for allergies. Social history and family history. The patient and her mother live alone in an apartment. The environment is reported to be clean and free of dust and hazards. No animals. Patient is not exposed to secondhand smoke. The mother reports that her mother's house is also clean and free of dust and hazards with no animals and no smokers in the home. The only relevant family history is that the mother does have a history of seasonal allergies. Review of systems, general. Mother reports fever and chills and that the patient has general malaise. Denies any night sweats or changes in weight. Skin. Denies rashes or eruptions, itching or texture changes. Head. Denies loss of consciousness, dizziness, or headaches. Eyes. Denies light sensitivity, pain, or change in vision. Ears. Denies odor, pain, or discharge. Nose. Mother denies nasal congestion but reports that the patient has a clear nasal discharge. Throat. Mother reports that patient complains of a sore throat and cannot swallow solid foods because of the throat pain. Mother reports that the throat appears to be red. Mother denies any oral sores or lesions, tooth pain, bleeding gums, hoarseness, swollen lymph nodes in the neck. Denies swelling to tonsils or tongue. Respiratory. Patient's mother reports constant wet cough. Denies dyspnea or wheezing. Cardio. Denies dyspnea, chest pain, or edema. Hematologic. Denies bleeding or bruising. GI. Denies nausea, vomiting, diarrhea, constipation, or any abdominal tenderness. Endocrine. Denies heat or cold intolerance, weight loss, or weight gain. GU. Denies any vaginal itching or irritation, dysuria. Musculoskeletal. Denies pain, swelling, restriction of motion. Neurological. Denies seizures, syncope, problems with coordination. Mental health. Slight irritability related to the acute disease process. Denies mood changes. Vital signs. Blood pressure 110/70, temperature 100.8 orally, respirations 20, pulse 97, O2 sat 100% on room air. Height 43.4 inches. The patient's weight 19.9 kilograms. The BMI is 16.3. BMI percentage is 78.8. Physical exam, general. Awake, alert, oriented times 4. No acute distress noted. Well groomed and appropriately dressed African American female. Skin is warm, dry, and intact. Appropriate color for ethnicity. No rashes or lesions noted. Head and neck is round to normocephalic. Trachea midline. Full range of motion noted. No limb adenopathy. Eyes. Pupils are equal, round, reactive to light and accommodation. Sclera is white. Conjunctiva is pink and moist, no drainage noted. Ears, tympanic membranes normal bilaterally with increased cerumen noted. Nose, clear nasal drainage noted. Bilateral turbinates with mild erythema and mild hypertrophy noted. Throat, the pharynx is edematous and erythematous. No exudates or ulcers, lesions visualized. Clear postnasal drainage noted. Tonsils present with moderate erythema noted. Tongue is midline without swelling. Airway open, uvula midline. No cervical node enlargement noted. Respiratory even and on labor. Clear to auscultation bilaterally. Cardio, regular rhythm rate, normal S1 and S2. No murmurs, rubs, or gallops. No edema to periphery. GI, round and soft, non-distended. Bowel sounds present times 4. No garden or tenderness noted. No hernia noted or bruise auscultated. GU is deferred. Musculoskeletal, full range of motion to all extremities. No tenderness or deformities noted to joints. Neuro, cranial nerves 1 through 12 intact. Patient is awake, alert, oriented times 4. Even and steady gait noted. Psychiatric, cooperative, and appropriate for age. The labs that I ordered were a rapid strep test and a flu swab. The primary interpersonal stressors that has affected this patient's physiological well-being is the fact that the patient has increased crying, she's irritable, febrile, sore throat, sleep disturbance, change in eating pattern, constant wet cough, runny nose. The interpersonal primary stressor identified that is affecting the patient's psychological well-being is the fact that the patient's mother is really worried about her child. The extrapersonal primary stressor that I noticed that is affecting the patient's socio-cultural well-being is the fact that the patient enjoys playing with kids at her daycare, but now that she is ill, she's not able to attend daycare and she is the only child in the home. Degree of stressor penetration. For this patient, the primary stressors identified are the fact that the patient has presented with a persistent fever, constant wet cough, and sore throat that presented abruptly 2 days ago. Stressors can be negative and positive, and both can cause a disruption in the patient's system. Once the disruption occurs, the patient is deemed to be symptomatic. Optimal patient wellness is the primary goal of the Newman Systems model. The Newman Systems model design consists of a series of concentric rings surrounded by a basic structure. The basic structure is surrounded first by the flexible line of defense, which helps to keep the patient stress-free. The second line is the normal line of defense, which acts as the patient's normal state of well-being. And the third line, the lines of resistance, which are the last lines to protect the basic structure, attempts to keep stressors from penetrating the core and maintaining client system stability. Once the lines have been penetrated, all 5 client system variables are affected. Unfortunately for this patient, all 3 lines have been penetrated as evidenced by the patient's body activating the immune response system. The patient is febrile and has a sore throat, but fortunately the patient's basic core structure is still intact. The goal is to now treat the patient with the appropriate medication so the patient can return to her previous state of wellness. The 3 differential diagnoses are streptococcal pharyngitis, acute rhinitis, and acute epiglottitis. The positive data for streptococcal pharyngitis is her rapid stress test was positive. She presented with an abrupt onset, high fever, malaise, prominent sore throat, dysphagia with solid foods, her pharynx edematous and erythematous, no nasal congestion. Negative data for strep. She denies arthralgia, myalgia, or headache, no exudates, and no diffuse adenopathy. Acute rhinitis positive data, clear rhinorrhea, postnasal drip, coughing, sore throat, and mildly edematous turbinates. Negative data for rhinitis. This disease process rarely begins before age 4. The patient denies nasal congestion, sneezing, itching, nasal obstruction, or nasal pain. She also denies itching and puffiness of eyes. The nasal mucosa is not pale or boggy. She's not mouth breathing, no cobblestone appearance of conjunctiva, no enlarged tonsils, no enlarged adenoids. The positive data for acute epiglottitis, she did present with an abrupt onset, pain and difficulty swallowing, febrile, and her pharynx is red. Negative data for acute epiglottitis, she denies severe sore throat, no protruding tongue, no drooling, no muffled voice, no stridor, no respiratory distress. Her pharynx is not beefy red, and no copious secretions. So the definitive medical diagnosis is streptococcal pharyngitis. The plan is based upon evidence-based research from Uphold and Graham 2013. The diagnostic, I performed a thorough history and physical examination, and the diagnostic screenings are completed. The rapid strep test positive, the flu swab negative. Therapeutic, prescribed amoxicillin 250 milligrams per 5 ml oral suspension. Take 2 teaspoons POBID with food times 10 days. No refill. This comes from Uphold and Graham 2013. Patient education, provide supportive care, increase fluids, get plenty of rest, diet as tolerated. Complete all of the antibiotic, even if signs and symptoms improve. Replace toothbrush, frequent hand washing, Tylenol or Motrin for fever and pain. Do not return to daycare until after 24 hours of antibiotic use and afebrile. Do not return to grandmother's house until the male cousin is treated. Report any medication side effects immediately. Report to the ED or return to clinic if symptoms do not improve or become worse. Closely monitor for persistence of symptoms longer than 1 week without improvement, respiratory difficulty, particularly stridor, difficulty in handling secretions, difficulty in swallowing, severe pain in the absence of erythema, a palpable mass, or blood, even in small amounts in the pharynx or ear. And this comes from Ferry 2017. The follow-up. Return to clinic in 1 week for follow-up and the flu vaccine, or sooner if signs and symptoms worsen or do not improve. Nurse practitioner interventions. Completed a thorough history and physical exam. This is direct clinical practice in secondary prevention level. Ordered appropriate diagnostic testing. This is direct clinical practice in secondary prevention level. Prescribed appropriate medication based on current clinical guidelines. This is evidence-based practice in secondary prevention level. Educated patient on disease process. This is guidance and coaching in tertiary prevention level. Educated patient on newly prescribed medication, including signs and symptoms and when to return to clinic or go to nearest ED. Guidance and coaching in secondary prevention level. Educated parent to provide supportive care. Guidance and coaching in tertiary prevention level. Client outcome goals. Client will comply with treatment plan. The nursing diagnosis, effective health maintenance related to compliance with newly established treatment plan as evidenced by the patient's mother ensuring that the patient takes the medication as prescribed for the full course of treatment. The client's parent will verbalize understanding of newly diagnosed disease process, nursing diagnosis, knowledge deficit related to disease process as evidenced by patient's mother able to verbalize signs and symptoms of disease process and recognize when to return to clinic or ED for any untoward changes. The client will maintain adequate nutrition and hydration. Nursing diagnosis, risk for imbalanced nutrition, less than body requirements. Risk factors are acute disease process, impaired swallowing, decreased appetite, and fatigue. The client will report that pain to throat has resolved. Nursing diagnosis, impaired oral mucous membrane related to inflammation or infection of oral cavity. The client will remain free of infection. Nursing diagnosis, risk for infection. Risk factor, exposure to pathogen. Hypothesis, if client completes entire course of antibiotic prescription as prescribed, have supportive care, increase fluids, and get plenty of rest, the client's symptoms will improve within 1 week. Evaluation process for plan and identified follow-up. The patient's mother was educated on the diagnosis and treatment of streptococcal pharyngitis. The patient has a very strong support system from her mother and grandmother. The patient's mother answered all questions without any difficulty and was eager to participate in the teaching and educating process. The patient's mother was provided with pamphlets on pharyngitis and educated on supportive care and medication prescribed for treatment. The patient's mother verbalized understanding of treatment plan and knows to return to clinic or to the nearest ED for any worsening signs and symptoms or no improvement in treatment plan. The mother was also educated that it is imperative that the patient completes the full course of antibiotics even if symptoms have improved to prevent reoccurrence of infection. The patient's mother was informed that if the treatment plan is successful, then the patient will be able to return to daycare after 24 hours of antibiotic use and the patient is afebrile. However, if the treatment plan is unsuccessful, then the patient will need to return to clinic for further workup, including further laboratory testing to work up other possible disease processes. The patient has a 1-week return to clinic appointment. Thank you, and this concludes my verbal presentation.